Hello, everyone, and good evening. Welcome to today's coronary atherectomy case competition final round. This is the competition that went out a couple of months ago. Out of many cases, these are the 4 finalists who are going to present their cases in front of an outstanding faculty. We have Dr. Mitul Patel from UCST, Dr. Dwayne Pinto from Beth Israels in Boston, and Dr. Poonam Velakapudi from Nebraska, University of Nebraska, and this is Manos Berlakis from Minneapolis Heart. These are the finalists: Dr. Eric Chang from Morehouse School of Medicine, Dr. Owais Idris from Pauley Heart Center in Virginia Commonwealth, and another Virginia Commonwealth, Dr. Kunal Kapoor, and finally Dr. Michael Megali from Banner University in Arizona. The presentations today, and then all of them will be archived, and you can watch them at cvinnovations.org. And then, without any further ado, I will let our panelists say a couple of words of welcome, and then we'll get started. So, Dwayne.
Hi, thank you very much, Manos, for that introduction. As mentioned, I'm Dwayne Pinto. I'm an interventional cardiologist. Really happy to see some friends here on the nice here and there, but also thank you for the time it's taken for you to prepare these cases for us to look at, and I'm looking forward to a discussion, an important discussion.
Wonderful, thank you. Poonam?
Hi, everyone. Thanks for joining us. I'm so excited to see all the videos of all these cases that I reviewed. You know, it's just been, I've been very anxious to see these cases. So look forward to all the presentations, and thanks to everyone, the audience for joining us, and thanks, Manos, for having us.
No, thank you so much. And then Mitul Patel had some emergency in the hospital, so he may be in and out through this, but no worries.
Can you hear me? Thanks, Manos,
Yes.
for having me, and thank you to all the presenters for some outstanding cases. We're looking forward to judging these cases and sharing some pearls of wisdom with everybody. I'm one of the interventionalists at UC San Diego, so thanks, Manos and CVI, for having me. I will fix my video. I don't know what's going on with that, but I'm going to hop out and hop back in.
So no worries. Thank you so much. And again, without further ado, we'll start with our first case. Again, Dr. Eric Chang from Morehouse School of Medicine will talk about unexpected bird detachment during rotational atherectomy. So, Dr. Chang, looking forward to your case.
There you go. My name is Eric Chang. I'm one of the cardiology fellows at Morehouse School of Medicine in Atlanta, Georgia. Thank you so much for having me. My case is an unexpected bird detachment during rotational atherectomy. My faculty mentors are Dr. Kumar and Dr. Sachdev, and I hope all of you are staying safe and healthy during this unprecedented pandemic. So without further ado, we'll go on to our case. So we had a 71-year-old, actually let me hide this side screen. Okay, a 71-year-old male veteran. He had a history of CABG in 2002 with a Lima to LAD, left radial to OM2. He actually came back in 2012, the RCA CTO PCI with 2 DS. And then in 2019, he had repeat PCI due to in-stent restenosis. A lot of other comorbidities: CKD, hypertension, diabetes, flutter, OSA, BMI of 40. He presented with progressive dyspnea and fatigue with minimal exertion for the past 5 months. And he specifically said he felt like the time when he needed a CABG. His home anti-anginal therapy included metoprolol, Imdor, ranolazine, amlodipine, and his vitals on presentation were within normal limits. So this was his ECG on presentation, which actually looks similar to his prior sinus, first-degree AV block, left posterior, and a right bundle branch block. So just a little bit of history. So this is his cath from 2019. Mind you, at that time, he presented with similar symptoms. He had some shortness of breath with exertion. We can see that he has patent grafts. He has a high-grade stenosis in the RCA, which was stented, as previously mentioned. And he also had high-grade stenosis in the left circ and in the diag. After this, he said he felt well. He went home. But then what happened?
But while you're booting up, it gives me the opportunity to ask Manos a question. It's interesting that he never got the bypass to to the right and then had to have CTO PCI later. So presumably that developed over the years, huh?
Okay, I'm sorry. Can you see this now?
Yeah, you can see you're fine.
Okay. All right.
Yeah, I think what Dr. Pino was saying is, why didn't he get bypass to the right when he got the bypass in the first place? So presumably he didn't have significant disease in the right at the time, maybe, or
Yeah, and to be honest with you, we never saw the records. He's a veteran. He was actually out of state, and it had happened about 10 years prior. So we didn't really have good history, to be honest with you, and we never actually got to see what was done previously.
Okay, great.
So as mentioned, 2019, he had this done. He came back. Let's see. Okay, so perfect. So in July of the year, the next year, he said he still has similar symptoms, and we recommended a cath at that time, but he said he really didn't want a cath. He was hoping to find out, how is he feeling based off of just imaging studies, and he had a nuclear stress at that time, and it was negative. And unfortunately, the patient, continued to have similar symptoms, and then he finally agreed to undergo angiography again. So a couple weeks later, same month, he came back. The RCA stents that had been placed the year prior were still patent, and it didn't really show much difference from prior. The grafts were still patent. We still see kind of the same stuff that we saw previously. And after discussion with the patient, he said, let's try to medically optimize, and that's what we opted for too. And we told him that if this continues, you can come back and we'll try to see if we can manage the circ and the diag. So of course the patient went home, he continued to have worsening symptoms, and he said, maybe I need to get something done. So that comes to us now. So this is now 3 months later, he comes back for another intervention. So some images here, right radial approach, we have the circ cross with the fielder. We have confirmed that we are intraluminal. FFR was performed, it was 0.66 with adenosine, and we decided to go with the rota. So on the right side, you can see the rota. It's 1.5 millimeter burr. It's heavily calcified, as you can see by the movement. It's getting some restriction there. It's heavily calcified in the main and in the left circ. I titled the Rotapalooza because there's a lot of rotaing going on. There's more rota of the left main going in and out of the guide catheter with the pecking motion, which is actually what is recommended by Boston Scientific. And on the right side, now we're getting a little bit over that curvature, hitting a little bit of the circ ostium. Once again, more Rotapalooza. We're trying to get through, trying to ablate the ostium and the prox circ, trying to make that good curve to cut through. And there is some advancement, as you can see in the next image. Everything is still moving. In case you're curious, the burst speed at this time was about 160K RPMs. There were no decelerations noted. However, unfortunately, after several passes, it was noticed that the burr was not moving at all. There were no decelerations, as mentioned. There was no changes in speed, no changes in RPM. The burr was not moving forward, it was not moving backwards. And it just kind of stayed there. And so then the question at that time was, is it that the angle that the burr was maybe trying to go over, was that maybe too acute? And maybe it got stuck. Just to show you, so this is after we had it removed, this is the burr image, and it was actually explanted. Kind of going back, so then how do you address that? How do you address the burr that is dislodged? A couple of different methods. You use a gooseneck snare to capture it. If you feel like you don't have additional support, you pass an additional guide wire so that you have more support and then grab it. Could you potentially leave the burr in the artery, given that, we know this area is already critically stenosed, maybe there's not a lot of myocardium being supplied. Could you potentially push the burr towards the side of the vessel and stent the lesion there? Or is there a way to apply some tension on the wire to attempt to dislodge the burr? Because the way the burr is fashioned, there's a distal platinum coil that actually prevents the burr from going forward. So with that knowledge, could you potentially just try to dislodge it by pulling slightly backwards? that was kind of the method that was done. As you can see here on the left, the burr is still not moving that well. The ribbon is kind of being pushed, brought back to see the response. As you can see, the wire is still intact. It is still responding. So gentle tension was applied, and which dislodged the burr actually, which allowed it to be then removed without complications. Now, an image afterwards show that there is still flow, there is no perforation, there is no acute vessel closure at that time. So once again, another repeat image from a different view still shows that we have flow, no closure, no dissection or things like that. So the lesion was actually then recrossed. It was recrossed with a smaller burr, or 125, and several passes were attempted at this time. It was 170K RPMs. There were no deceleration notice and such. So once again, more rota, lots of rotapalooza going on. The wire was then repositioned further. And then we get to ballooning and then stenting of the vessel. And then as you can see, the vessel looks a little more plump. After this, it's more rota in a sense to diag. The diag at that time, the FFR was 0.76. Same thing with the rota, more rota being done here, as you can clearly see on the right side. Okay, some rota exchange. As you can see, there is some staining on the right image, likely guideliner dissection. Long stent was placed there. A long stent was placed from the main to the left circ. Kissing inflation was performed. And as you can see in the final shot, there's improved flow. Now, mind you, the images are a little unclear. I mean, the patient does have a BMI of 40, so that may have been contributory as well. So in terms of the angiography itself, the amount of contrast used total was 145 cc's. It took about 76 minutes or so. And the radiation was about 104. So, you know, just some discussion. So as we know, rotational atherectomy is a good way to modify heavily calcified lesions, but there are very specific complications that are specific to atherectomy, because you have the vessel, you have the burr, and then you have the way that these two things interact with each other. So you can get very unique complications such as burr entrapment, and the burr can also damage the guide wire itself. However, there have not really been reports of the burr detaching by itself. And the etiology of detachment in our patient is actually unclear. We've actually sent the burr over to Boston Scientific, and I'll show you an image of the burr in a little bit as well. So, you know, what are some reasons that these things can happen? You know, could there be just anatomical issues? Maybe the lesion is just too complex. There's too much calcium in there. Or could it be, as we saw, maybe that bending, that tortuosity, maybe that impeded the movement of the burr, and that's what caused things to just kind of slow down and maybe get lodged there, excuse me. Now, could there have been issues with the burr itself? Was the burr maybe too large for the lesion? Or could there have been inherent mechanical defects that we were just, you know, manufacturer defects that we're unaware of? So, you know, just kind of looking back, you know, there are some FDA reports that kind of talk about these things. And specifically, you know, the reports talk about tortuous, highly calcified, very tight lesions.
Dr. Chang, one more minute, because we're really above the time. Okay, if you don't mind, one more minute, if you don't mind.
Okay, no problem.
Great.
So, and, you know, the burrs, detachments and things, but, you know, unfortunately what they say is that these are operational context. Which is not really very helpful. So once again, a conclusion, you know, spontaneous burr detachment is rare, but it can be devastating. Depends on a lot of different factors. And, you know, the utilization of this technique, although it's very unique and can be very helpful, it should be performed only by highly experienced interventionists so that unexpected complications can be addressed immediately. I just want to show you the image of the burr itself. So on the top, where the arrow's pointing, that's the location where it appears to have uncoiled. That's where it's separated. And if you actually look at the bottom, you can see as you look at the left side of the screen, the coiling is very tight. and then the coiling becomes a little more loose. There's an area of separation on, and then towards the end, that's where it kind of broke off there. So maybe this is why. We actually had a meeting with Boston Scientific today, and they said they were going to investigate to figure out why. Maybe it was an engineering defect or an inherent defect.
Wonderful. Yeah, thank you. Excellent case. And maybe we'll start, you know, Dr. Velakapudi, put up any thoughts. I mean, maybe everyone in the panel can say, what do you think this happened? And anything else that can be done.
I felt like maybe it got stuck, the burr was stuck in the calcium, and that's where it got detached. And I usually also try two other techniques. I try to wire beside the burr and try and balloon. And the second thing is to push a guide liner all the way down to the burr and then try the push and pull technique. Just one quick question I had was, did you do imaging of this vessel at all? And why did you pick the 1.5 burr based on what?
So the question was, do we do imaging? And so there was no imaging done prior. And to be honest with you, I'm not exactly sure why exactly the 1.5 millimeter burr was picked, to be 100% honest with you. But I do know that it seemed to work better with the smaller one. So maybe the 1.5 baby was a bit large. And there have been studies that show that, you know, if the burr is too large, it inherently increases the risk of both, you know, failing the procedure and maybe there being getting stuck.
I know Dr. Pinto has done some of these cases without Rotaglide. At least I've heard him talk about that. But did you guys check to make sure your Rotaglide was dripping through appropriately? Because
Yes,
that's the other
everything
thing.
was working, yes. And
Yeah, we actually, as Matul says, we never used Rotaglide. I did 2 Rota cases today. Been many years we haven't been using it, so I'm not sure that actually leads to more problems. You definitely had the brake on, right? Yes. I mean the spinning thing, because you know one mechanism with that angulation is if the wire was spinning in there, which it does if you don't have the white thing on, the spinner clip on there, then you know that could heat up and that fulcrum could cut the shaft at that point. But it looks like there was either fatigue or some problem with the shaft. I think one of the options you gave is to say that the artery was too small. Let's just leave it there. That like is intellectually incompatible because you went to fix it in the first place because it was big enough. So that's never the answer. Otherwise, you shouldn't have embarked on it in the first place. And in general, the size of the burr is the board's question is 0.8 or less for burr size in general. I shy away from the 1.25 except for very selected circumstances, maybe like this, because as you could tell from the size, the shape of the burr, it's shaped more as a watermelon seed rather than olive pit. And for that reason, when you have forward tension, it can slide in and then get entrapped because you can't pull it back.
Right.
So unlike the orbital that has can burr in both directions, if you push with the 1.25, sometimes it slips through, but you can't get it back out. And then, you know, the easiest one strategy is what Dr. Velakapudi said, which is you put a guide liner down and you pull back on the wire so you got it on both sides. That necessitates cutting, you know, separating the rota and putting the guide over it. But I'm sure Manos has come up with, you know, 20 other ways to do this. And I'm sure there's an algorithm in his very good book, the Manual CTO Intervention, which you should all get.
Well, there is an algorithm, but I think it was handled very well. I think, as you said, I mean, the algorithm usually says start with the simpler things and then go to the more aggressive things down the line, right? So you get a wire next to it, balloon around to it. But here it was different because usually the problem is rotablator being stuck. But here actually it wasn't stuck; it was just broken off. So the reality of it is, you know, the solution was what exactly we did. You know, the wire distal is thicker, so by pulling the wire back, we're able to get it through. Of course, it's a fortunate thing that the tip didn't break off because that's the other risk there. And I think that's where the guide extension would have been very useful. but it was very elegantly done, I think. And then there was a question from the audience about why you chose 1.5.
Yes, and I think someone else asked that. So, and to be honest with you, I'm not exactly sure. You think another size would have been, yeah.
I think it's a common size, right? Most people like to start with that. So wonderful. Well, thank you so much. And let's move on to Dr. Oais Idris, who is from Virginia Commonwealth. He's going to talk about 22 passes for bursts and 1 MCS. So very exciting, the story of a DK cross bifurcation. Dr. Idris.
This was a case that we did a few months ago, so we'll get started. So this was a 73-year-old gentleman, low BMI, low, for an American, 21, and he had a history of CAD, status post POBA in 1999 on the LAD, and then a stent in the mid RCA in 2012. He had paroxysmal AFib, diabetes, dyslipidemia, hypertension. The more recent stuff that had been going on with this gentleman was that he had esophageal cancer, status post resection. It was not metastatic or anything like that. But then he also had newly discovered exophytic masses in the right kidney, which were questionable renal cell carcinoma. He also had a recent DVT that he was on Lovenox for. So quite a few things this gentleman unfortunately had going on. And then he also had baseline dyspnea, NYHA class 3. So he was transferred from an outlying hospital. He was referred to us at VCU after he presented there with a polymorphic ventricular tachycardic arrest. They did an echocardiogram at the outlying facility, which we just basically have the report for, and I think we did get the imaging eventually, but EF was 58%, so normal. He had known aortic root dilatation on the echo. It was noted to be 5.0. His labs were essentially unremarkable except for his hemoglobin, which was 8.6. He was on optimal medical therapy. And this was his cardiac cath that was done at the outlying facility. So, on this left image that's playing right now, you can see that he's got a heavily calcified LAD, and then this bifurcation, the LAD diagonal bifurcation is heavily calcified, is severely diseased. Medina classification 111. He also, let me play this video here. He also had a significant lesion in the circ at this OM1 bifurcation. His syntax score was calculated at 30 total, 24 in the LAD, 6 in the circ. He did also have a patent stent in that RCA, which I don't have image here. So this was actually his right heart cath that we performed. When we intervened on him, I just put the numbers here just to make it easy. So as you can see here, his cardiac index was, borderline. Same thing with the cardiac output. Blood pressure was okay, but his PA-SAT was also low. LB, EDP, and wedge were actually good. So he was well compensated. So after he was transferred to us, and actually this is the RCA here. I thought I didn't have this picture, but there's your patent stent in there. So after he was transferred to us, he was seen by surgery. He was a surgical turn down due to his ongoing cancer as well as other comorbidities. His STS score was around 3, but that didn't take into consideration his frailty. We already talked about the syntax score. And so we decided that, the best thing to do that he would benefit from would be to undergo the PCI on this LAD and the diag. And then we'd eventually evaluate his circ after that. So our procedural strategy going in was that we would use an Impella CP via the right femoral arterial approach, and then we would use a single access technique through the Impella sheath. Our plan was for rotational atherectomy on both the LAD and the D1 bifurcation, and then to do a DK crush with OCT guidance. So here's our first picture with our guide. You can see that we already have the Impella in place here, and this was looking at more or less the LAD that let me go to the next picture because that's a better image, and those are working. So this is our target right here, heavily calcified LAD diag D1. So initially we started off with a 1.5 burr because we assumed we gauged the vessel to be about a 3.0 vessel. So here we tried 7 passes. As you can see that this didn't unfortunately work. We weren't able to cross with a 1.5 burr. So at that point we reassessed and said, well, maybe we have to go smaller. And we did 5 passes with this 1.25 burr. This is obviously a roto floppy wire that we're working over. And 5 passes here. So that crossed, and then we went back in again into that LAD because we knew it was a bigger vessel. And we ended up doing a 1.75 burr, 7 passes with that. So at that point, we were already up to 19 passes. And we did, here's our result after that. So still looks pretty good, but the diag obviously is still no dissection. The diag still has, significant calcification. So we wired that and did 3 more passes for a total of 22 passes. The first 1.5 burr that we used was unable to cross. So we actually had to use a new 1.5 millimeter burr. Remember, we did 7 passes in the first LAD lesion with that. And so here's a picture of our 22 passes with 4 burrs. It was almost 8 minutes of procedural time. So on the LV EDP front, with every atherectomy, we did see our LV EDP on the impella console go up, and it was as high as 30s here, and then with the 1.75 burr as well, it was similar, and then there was some profound blood pressure drops during the atherectomy. Here's our imaging that we did after we ended up doing the atherectomy. So we had insufficient plaque modification, and then this was the bifurcation here. I have another OCT picture here. So I'll just let that play for a second. But at this point, maybe a little bit of dissection here in the LAD, but at this point, we used some NC ballooning and some atherotomy, I'm sorry. So we pre-dilated here with a 2.5 and a 3.0, and more pre-dilation here. Just got pictures. Then here's the atherotomy that we did with a Wolverine 3.0 in the LAD, and then a 2.5 in the diagonal. So after we did this preparation, this was our LAD OCT. And at this point, I didn't mention, but we had wired the LAD with a run through and Xi'an blue in the diagonal. So good plaque modification on the OCT here. And so we ended up obviously going with the DK crush technique that we talked about. So we ended up stenting the diag first with a 2.5, and then we crushed it with a 3.0 NC, and then we ended up doing the first kissing balloon inflation that you guys see here on the right side. Then we ended up going in with a 3.038 stent Zion Sierra, and ended up deploying that across the bifurcation. And we did our second kissing here with a 2.5 NC in the first diagonal and a 3.0 NC in the LAD. Then we did pot with a 3.5 NC, and then another Zion Sierra that we overlapped distally into the other stent, 3.518 here. We post dilated with a 4.0. And this is what we got. This is the OCT of the first diagonal. Our MSA on the first diag was 3.43, so very, very acceptable. And here's our MSAs on the left side, and I'll play this OCT. But essentially, well-opposed stents, I should say, in the LAD, well expanded. Our MSAs, proximal LAD 9, mid LAD 6.5, and distal LAD 4.8. And then this is our final picture, essentially 375 mLs because of OCT of contrast that we used, and 80 minutes of fluoroscopy time, and the total procedural time was just over 4 hours. The right heart cath after the procedure, still showed that actually the cardiac index had gotten further down after the atherectomy and the atherotomy and balloon and stenting. The PA-SAT also went down from 54 to 39. Essentially, with this mechanical circulatory support, we mitigated adverse effect that was induced by the atherectomy, and essentially supported myocardial recovery and minimize the risk of periprocedural MI. So there's a couple of papers that have been published on this, just very quickly, on this myocardial stunning post atherectomy. So this was from 1996 from Jack, and this was essentially where they measured the prevalence and the timing of regional myocardial dysfunction after the rotational atherectomy versus POBA. And as you can see here, that recovery to baseline was mentioned at 153 minutes versus 2.6 minutes, so very, very significantly different here. And the mechanisms that were mentioned were distal embolization. Obviously, with rotational atherectomy, we do get macro emboli. Sometimes you get the coronary vasospasm, but more importantly, this microvascular flow disturbances. And here's another picture from Jack that was just published actually last year. And this essentially compared Impella and looked at IMR, which is index of microcirculatory resistance, as well as the coronary flow reserve. And it was mitigated by Impella. Here's our LV-EDP after our atherectomy. This is on P4, as you can see here. And then we did end up taking out the Impella because of the mild oozing that he had around the access site, and closed with a per-close pro-glide sutures that were deployed before the procedure. Clinical course was just complicated by essentially pneumonia. Troponin peaked at just 0.5, and then the CKMB was only 12. This is considered very low peak considering how aggressive we were during the procedure. And then just a few, and the patient was discharged on post-op day 14 because of the pneumonia complications. He didn't have any vascular or cardiac complications afterwards. We also decided against revascularizing a circ because he didn't have any symptoms, and based on his coronary disease and his other comorbidities, in this gentleman, we decided, that if he started having symptoms, that's when we would pursue that. And last is our teaching points for this case, that, regardless of baseline LVEF, if you pursue very aggressive revascularization like we did in this gentleman, you may induce significant hemodynamic compromise despite having a normal right heart catheterization. So mechanical support mechanical circulatory support can actually mitigate that prolonged myocardial stunning that can be caused by atherectomy, ballooning, stenting, and it can prevent periprocedural MIs. And in this setting, it definitely afforded us a great degree of confidence in achieving optimal results. That's why we used 4 different burrs and, took our time with when it came to, doing atherectomy and preparing the lesion well. That's basically it.
Wonderful. Well, thank you so much. This was an excellent presentation.
Thank you.
And we got many questions from the audience. For example, one of them was about the when to do atherectomy in cases, mechanical support in case of atherectomy. So maybe we'll open it to the panel. and start with Dr. Patel. So Mitul, when would you do mechanical support in which atherectomy cases?
Yeah, it's a great question, Manos, and that was a great case. I think, you know, it's certainly in patients with impaired hemodynamics, which we usually do a right heart catheterization to decide, you know, elevated wedge, poor reserve, et cetera. Low EF patients where you're planning extensive atherectomy like was done here, or when you're performing atherectomy in a vessel that has a CTO in the contralateral vessel or extensive disease in the contralateral vessel. So multi-vessel disease, low EF, poor incoming hemodynamics are three areas for sure.
You know, I agree. Yeah, a couple observations. I want Dr. Chang's X-ray equipment because with the guy with the BMI of 40 and 70 plus minutes of fluoro to have only 100 milligray is kind of what I want. But with Dr. Idris's case, this is a more conventional amount of radiation therapy with 1,000 milligray. But I actually blame his drop on of cardiac output on Dr. Idris and his poor management of the TUI during the long procedure, because he saw that actually his RA pressure dropped to 4, and it was at 10 earlier. So I suspect there was a significant amount of blood loss during this 4 or 5 hour procedure. At the beginning of the case, he was on the dry side already with an RA of 10. So his drop in cardiac output may not necessarily have been from stunning. In fact, his LVEDP had normalized by that time, it appears, and his RA pressure was lower. So I don't know that actually he was that much worse, which is why he tolerated actually having the impeller removed at that time.
Yeah, I had the same question. I mean, I don't know that I would have used an impeller up front. I wonder why the cardiac index was first off so low. I think his EF was completely normal. So the question I have is the left circ looks significantly diseased. This is a diffusely diseased LAD diag system, but the left circ looks like it's also a 90% lesion. So if I was putting an impeller and doing all this, I probably would have completely revascularized this patient. But I'm curious as to why the left circ was not thought about being revascularized first instead of going after this diffusely diseased LAD D1 system.
So because of the tortuosity and because of the contrast that we use, that's why we did this peri-procedural planning beforehand, that we were going to aim for the LAD and the diag, which, you know, obviously would be supplying a much larger amount of myocardium versus the circ, which I agree, you know, in that view that we got, and we took some other pictures that I didn't include, but that did look like, you know, that could have been even more significant than possibly the LAD. So unfortunately, the imaging wasn't the best for the circ. But based on, you know, the amount of myocardium and you know, what we were attempting as far as, you know, atherectomy, and if we hadn't used OCT, if we used Ibis, maybe we would have been able to do the circ as well, given, you know, given that the Ibis wouldn't have used contrast. So that was one of our thoughts on that. But this guy, once again, was very frail. He had ongoing cancer. He was undergoing treatments for cancer. He had newly diagnosed renal, you know, masses and whatnot. So for this gentleman, we decided that, you know, let's hit the one with the biggest territory that is supplying the largest amount of myocardium.
I think it's also, you know, what you're going into the case planning to do. If you were really convinced you needed to do the circ, you wouldn't have done so many OCT runs.
Sure.
And in the end, you would have saved the dye for the circ if you really felt like you needed to do it. I think you kind of halfway wanted to do it. Like if it went really easy with the LAD and the circ, you would have gone for the circ. LAD and the diag, you would have gone for the circ. But in the end, I actually don't I like OCT, but I don't reassess after atherectomy to see whether I've had adequate, with OCT, adequate plaque modification. I just balloon it. And if it expands, then, you know, I'm happy because then I will do some post-dilation after the stenting. and I'll do a final OCT run. And that way I limit the amount of contrast that I'm doing. But, you know, listen, I'm relatively new to OCT, so I'm interested to learn from others. But, you know, I rarely give that much contrast, even for a complex case.
Excellent, so great points. I think
LED looked like. Did anybody see that? I didn't see that on the OCT, the ostial LED.
Yeah, I can pull it up real quick.
Well, actually, you know, we'll have to go to the next one because we're out of time. But again, if you don't mind, actually, Dr. Idris, there's many questions that came up from the audience. So if you don't mind answering them, typing the answers, that would be wonderful. So we can move on to the next case. But again, phenomenal presentation. Thank you very much.
Thank you.
And then we'll continue with.
By the way, your average burr run was 21 seconds. So if you had 30-second burr runs, you wouldn't have needed 22.
There you go. So we'll move on to Dr. Kunal Kapoor, again from VCU, who's going to talk about laser atherectomy to recanalize the CTO, secondary twin stent undersizing and under expansion. Dr. Kapoor.
My name is Kunal Kapoor, and
I'm April Shoemake. I'm an interventional cardiology fellow at VCU.
And I'm a general cardiology fellow at VCU and the Poly Heart Center. And we would like to thank you and welcome you to our presentation. Here we hope to share with you a very interesting case using laser atherectomy to manage a chronic total occlusion due to complete in-stent restenosis from an undersized and underexpanded stent. We will focus on the utility of Ibis and mechanical circulatory support to optimize hemodynamics during complex interventions. So our patient is a 55-year-old African-American male. He has known coronary artery disease and has had numerous PCIs to OM1 and the RCA with multiple recurrences of in-stent restenosis. He also carries a diagnosis of heart failure with an ejection fraction of approximately 20%. Most notably, 4 years prior, he underwent an unsuccessful CTO revascularization attempt of OM1. He now presents with dyspnea, exertional dyspnea, as his anginal equivalent. He has NYHA class 3, CCS class 1. His Seattle Angina Questionnaire score is 71 out of 100, and he has a Rose dyspnea scale of 2 out of 4. His nuclear stress test revealed a reversible defect in the anteroseptal, inferior, and inferolateral walls, comprising 12% of his left ventricular mass, consistent with ongoing ischemia. On his medications of note are 2 antianginals, isosorbide dinitrate and metoprolol. He is also on aspirin and high-intensity statin therapy. We show here his right heart cath for a particular reason. Even though his numbers do not indicate signs of significant decompensation, due to severe left ventricular dysfunction, multi-vessel coronary artery disease, planned CTO intervention, and need for atherectomy, we elected to use Impella support. The patient was known to have triple vessel disease. He has an OM1 CTO with a JCTO score of 4. The distal vessel is not seen, but remember there is ischemia and viability in this territory. Furthermore, we noted that his LAD had proximal and mid 70% disease with serial stenoses surrounding an aneurysmal segment. His RCA also had a mid-vessel in-stent CTO. The patient was evaluated by cardiothoracic surgery, and he elected to undergo sole percutaneous intervention. We made the decision initially to focus on the LAD and OM1. The RCA CTO would be staged later as a secondary procedure.
So we first turned our attention to the LAD. We placed 2 overlapping stents, a 4.0 Synergy drug-eluting stent in the mid-vessel, and then a 5.0 Synergy drug-eluting stent proximally with overlap. We then IVISed to make sure that we had sized appropriately and post-dilated enough, and we had well-opposed and well-expanded stents. Of note, especially during ballooning and stenting of the LAD, we noticed systolic blood pressure drops and our LVEDP increases. Then we turned our attention to the OM1 CTO. We started with antegrade wiring with a Gaia third. We were able to stay within the stent and within the true lumen during antegrade wiring. And as soon as we reached the distal stent, we de-escalated to a gladius to wire the very small kind of atretic distal vessel. Next, we pre-dilated with a 1.0 sapphire balloon and then a 2.0 non-compliant balloon. And after which, on angiography, the distal vessel started to become apparent. We'll see the Ibis on the next stent, or on the next slide, showing severe underexpansion and undersizing. But here we see one pass of laser atherectomy, which we did with a 0.9 XAD catheter at 60/60, and we did 6 runs. We also saw LVDP increases and systolic blood pressure drops with our atherectomy runs. So here was our initial Ibis. You can see the entire run here. We basically found an area where we had 1 layer of stents, and then more proximally in the vessel, 2 layers of stents that were a size about 2.5, while the vessel was at least a 3.5, if not a 4.0 vessel. Next, we dilated the entire vessel. We did atherotomy with a Wolverine cutting balloon within the stent, a 2.75 within the 2 layers, and then I believe a 3.25 at the ostium of the circ, followed by a 3.5 non-compliant balloon at the ostium. Next, we just stented the ostial circ with a 3.5 Synergy drug-eluting stent with minimal overlap to the area of old stents, mainly to make sure that we did not do 3 layers of stents in addition to the 2 that were already there. We then post-dilated with a 3.5 non-compliant balloon, and here is our final Ibis with an MSA of 7.8 at the 2-layer in-stent restenosis site.
The final angio confirms a good final result with TIMI-3 flow in OM1. We removed the impella within the lab itself. The patient was discharged the following day on dual antiplatelet therapy, and at 1 month follow-up, he noted improved symptoms and no further episodes of chest pain. Given symptom improvement, we plan to tackle the RCA-CTO only if he had notable ischemia on follow-up stress imaging, which is scheduled within the next 2 weeks, actually, from today's presentation. We would like to thank you for your attention. It has been a privilege sharing our work with you. We hope to leave you with a few teaching points before we close. Primarily, stent undersizing and underexpansion can predispose to severe in-stent restenosis, leading to a CTO. Ibis is very helpful in diagnosing mechanisms of stent failure and guiding next steps in treatment. It is also helpful in optimizing the final results and ensuring long-term patency rates. Another key takeaway is that even if a patient has near normal right heart cath values, those with left ventricular dysfunction are vulnerable to hemodynamic compromise, especially if aggressive techniques such as atherectomy are utilized. Use of impella supports hemodynamics and allows for the lesion to be prepared most optimally. And we would like to, most importantly, thank you for organizing this conference and this opportunity. And we hope we'll get a chance to share further work with you in the future. Thank you.
Wonderful. Thank you very much, Dr. Kapoor, Dr. Shumaker. I love the choreography. You guys had very all orchestrated going back and forth. So congratulations. This was a very well-done presentation. And maybe we'll open it up some discussion. I know that Dr. Pinto is a lot of a big fan of laser when he doesn't do rotablation. So any thoughts, Dwayne, would you do the same thing? Would you do something else first? What are your thoughts?
I think, here is a nice case for laser atherectomy with 2 layers of underexpanded stent. I do want to point out that this is a very common, finding. And Manos, who's a world expert on CTO, PCI, and imaging, will attest to this. I think is that we very often see these underexpanded or undersized stents, yet we blame it on the patient. We say, oh, they have hemoglobin A1C of 14, or they're still smoking or whatever, but that may be true. That may be a modifier, but we really cannot afford to do things like this. So I really applaud you and the operators doing this case. And remember, 5.0 stent was put in that LAD. That takes some gumption, and it sounds like that was put in before even there was imaging. So, I think sizing these stents appropriately, I think learning from these cases that, it's easy to go in there and just throw in another stent, but that would be wrong. We need to really size these appropriately. I will point out too, he has a really cool myocardial bridge in the apex. And some would say, oh, maybe he's having chest pain from that. Do not let anybody stent that apex because he's still having chest pain.
Perfect. Thanks, Matt. Poonam, any thoughts?
Yeah, great case, nicely done. I just, the myocardial bridge is just taking away all our attention. But I just want to make two points are that, you use the right, with the laser atherectomy for if there's any fellows or early carriers, then, you use, if it's a native vessel, you want to use a lower fluence and rate, right? So maybe 20, 30. So here 60 was used. The second thing I noticed was you used the Wolverine balloon was only 275, whereas the vessel measurement was close to 4. So I thought that was a little, a smaller size balloon. Maybe you could have used a bigger balloon in that situation there, because it probably wouldn't give much of an expansion, given that the stent itself was 2.5 or 2.75. I think those are the points I wanted to make.
Manos, can I ask you a question? What's your usual progression for the 0.9 laser, and what kind of fluency do you go to? And then when do you start adding contrast? Is it after you've gone to 80/80, or what's your progression?
Yeah, great point. There's no right or wrong. I must admit, personally, I go to 80/80 from the beginning. For instant, right? For instant, I got 80 to 80, and quite often these days I give contrast on the first passes as well. I found that laser alone, without contrast, instant is not working often very well. It worked out great here, but I think for most cases I've done, until contrast goes in, it doesn't have much. Now, when I give contrast, it's very limited injections during the laser activation. There is the 10-second pause between the 10-second duration run, but I do go high fluency and high energy. Again, maybe that's a little more risk. The one thing you have to be careful for this, in case sometimes you get bubbles. So you're lasing and you see bubbles forming at the tip of the laser, and that's obviously not a good thing. You have a lot of no reflow or potentially bradycardia with that. So again, there's no right or wrong, but I think at this stage, earlier, I think it's better to go more conservative, to be honest, sometimes, than to go more aggressive. But I think for stents, 80/80 works pretty well most of the time. Given the limitations of time, again, congratulations. That was an excellent case. If you don't mind stopping the sharing, so that Dr. Michael Megali can present his last but not least case. His case is about multi-modality techniques to treat balloon uncrossable lesions. So Michael, go ahead.
Thank you so much for inviting me here. We have a little crunch on time, so I'll go directly to the meat. I'm Michael Megali. I'm at Banner University.
Don't get nervous because I see a sheesh is on.
Well, that's pretty good. Okay. All right. So my case is about using atherectomy techniques to overcome balloon uncrossable and undilatable lesions. And going straight to the case, our patient is so our patient is a 68-year-old man, EF of 15%, and he had a previous non-STEMI where the ostial LAD was stented, but they could not cross the mid-LAD. So he was actually referred for completion PCI of the LAD. So as you see his images here, he has a circ CTO, and the LAD is stented up to the mid-segment, but after that, there is a long, severely calcified lesion that could not be crossed before. So we started by wiring this. The wire went pretty easy, but then it was balloon uncrossable and nothing could cross. We tried multiple techniques here. We tried small balloons. We have 1.25 balloon that did not cross. We tried different microcatheters, including Caravel and Turnpike LP, did not cross. We had increased guide support with guide extension, and we even attempted to like shove the balloon deep into the lesion and try to perform balloon angioplasty proximally, but nothing could cross. So looking at the famous algorithm, we felt that we did most of the things that we could do, and the only option that we had at this point is to proceed with laser atherectomy. And one of the benefits of laser is that you don't have to exchange the wire and you don't need a microcatheter to cross. So we performed laser atherectomy, I believe, at 40-40 or 60-60. And it was just 1 or 2 passes. And after that, there was, as not very unexpected, some dissection in the vessel. But after that, the microcatheter could cross easily to the distal vessel. And then we exchanged the wire to a more supportive wire. We used the wiggle wire. And then performed multiple balloon angioplasties. As you see here, balloon angioplasty, the balloons still are undilatable. So we solved one problem with going through a balloon uncrossable lesion, but still this is still a balloon undilatable lesion. After balloon dilation, the dissection got a little worse. But at this point, we thought of our options, and our options were not many. So we opted to perform a quick run of rotational atherectomy, knowing that we are in the subintimal space. So the intentional subintimal rotational atherectomy we performed with a 1.5 burr at a high speed, 170 kRPM. It was a short segment. We did like 1 run of this. And then we placed the 3.0 by 48 millimeter synergy. And then after Ibis, we aggressively post-dilated. And this was our final result. And like a very few words about subintimal or subadventitial, maybe the right word, subadventitial rotational atherectomy. The adventitia is very stiff. And this was even noted in 1938 in the book of Biology of Atherosclerosis, that another feature of importance is the great tensile strength of adventitia. If it was weak, it would the inflammation would erode into the pericardium, would die. So it's actually an evolutionary process to have a thick adventitia. It's when atherosclerosis happens, usually thickens more over the plaque. And the reason it's thick is because it's full of fibroblasts, no smooth muscle cells, no proteoglycans. So it doesn't get weakened by inflammation histologically. And instead, it forms some fibril collagen that surrounds the atherosclerotic plaque that later on gets calcified. So the subintimal or subadventitial rotational atherectomy is actually advised against by the European expert consensus because of the increased risk of perforation and extending the dissection. And when we think about it histologically, I mean, if the adventitia gets thickened around the very tough lesions, and the fact that we use rotational atherectomy, if we use it subintimally, it would be in arteries with circumferential calcium, circumferential calcification. So that's one way to think about it. But if done, it should be done very, very, very cautiously. These are the few case reports I found in the literature. Actually, one of them is Dr. Aslani. I think he's in the audience right now. In 2018, when we used subintimal antegrade rotational atherectomy to facilitate reverse cart, he used a 1.25 millimeter burr and 180 kRPM. Another case, we used the same technique just to overcome balloon undilatable lesions after successful reverse cart. So these were just a few words. Our take-home points here is that in balloon and microcatheter uncrossable lesions, laser can be very helpful. Actually, in our case, it was like the only thing left, I think. And if you have to do rotational atherectomy subintimal, it should be very, very cautiously done. And generally the recommendation is you do it in a straight segment using a smaller burr, shorter runs, and very high speed to avoid the burr getting stuck. And thank you so much. I think I learned time management from the best.
Wonderful. Thank you again. Thank you. That was a great presentation. And I see that Dr. Prasad actually put some notes on the note that this was in a dissection plane, so maybe not exactly subintimal. I guess my question about the subintimal is, as you said, it can be hard, but most of the time, actually going to the subintimal space is the solution if you have a balloon uncrossable or undilatable lesion for that matter. Because you essentially push the plaque in one direction, whatever is calcium or else is causing the problem. But again, curious to hear the thoughts of the other people. I don't know if Dr. Patel is on. Are you still on?
Yeah, I'm still here. Sorry, I'm just driving between hospitals for a STEMI. But no, that was a fantastic case, Michael. I think you guys pointed out all of the salient features of working in the subintimal space. It's obviously not for, someone that hasn't done probably 150, 200 rotablator cases and isn't at an experienced center, but definitely make sure that you have your bailout equipment in the room, things like covered stents. In this case, you already had a guideliner in because you were having trouble crossing, so getting a covered stent down there wouldn't be an issue if you perforated. I think you showed exactly what you do in this circumstance. It would have been great if the laser would have done enough to be able to expand the balloon there, but as we know, laser works great to melt the proximal cap, but it doesn't do much for calcium. And so I think you had to pull out what you did and got a fantastic result. So congratulations.
Wonderful, perfect.
There are a lot of comments on, why use the Impella, and I do just fine without Impellas, and with a couple of comments on that. And one is certainly, I don't think, as was said in the comments section, or we've said many times, is simply because it's a left main or simply because somebody has a low EF doesn't necessitate using an Impella. But I think knowing whether somebody is decompensated from a right heart cath is one method to help select the right people. Knowing what reserve the person has with regard to their coronary blood flow because of how much myocardium is at risk and how much you're putting at risk when you're fixing is a certain thing. But it's difficult to prove the counterfactual that I did a case with an Impella and without it they would have done badly. But I do have a number of cases where I have what's termed Impella regret, and I have shared these in open forums of somebody who's died on the table where I said, let's just get in and get out. And we had, calcium and stents dripping off and things like that. And I think the idea too of getting in and out when you're doing, for example, a left main DK crush and you want to image and do things in a methodical way. I don't know whether it's worth, $25,000 as far as the dollars, but I just would put it into your calculus of getting in and getting out may not be what you would normally do if you weren't stressed for time or for the hemodynamic status of the patient. And do you want to have to come back and fight a left main restenosis or things of that sort in somebody who's not a surgical candidate? So it's a lot to think about. I don't think that, I think we all can agree that there's not definitive, data out there to say who are the exact people to benefit. But what I will also say is you can completely burn the benefit of an Impella with a vascular complication. So all of the cases here, the patients did fine with the Impellas being removed, but we all have to be very good at vascular access and closure so that we don't lose that benefit.
Wonderful. Thank you so much. Poonam, any final comments? And then we'll announce the winners.
One quick comment I wanted to make was great cases and very well done. And everybody was very well thought out. The indications are really important and planning the procedure well. And I think the antiplatelet therapies are something also that we really have to keep in mind. And what a great cases. Everyone did such a great job.
Wonderful. So the winners are And the first one is getting $500, and that's Dr. Michael Megali. Second is Dr. Kapoor and Shoemaker. And third is Dr. Chang. Congratulations. Again, congratulations to everyone today, us, Dr. Idris as well, and all the others who submitted cases. Thank you all. I would like to thank our panel for excellent comments, and thank all the presenters for providing excellent presentations with a great learning experience. So thank you again so much, and look forward to seeing you, hopefully in person, at one of the meetings soon. Thank you so much.
Thank you.